guys. My name's Callum. I'm a student healthcare scientist and I work at West Suffolk Hospital in Diagnostic Cardiology. So next up, I've got a case study. This is just sort of an example of, I try to use a case study which collaborates non-invasive and invasive cardiology. Again, sort of things I'm early into in my training, but things that I've come across this year. So hopefully this case study will kind of knit together a bit of invasive and non-invasive cardiology. So the case study is a patient with severe aortic stenosis, which is a condition where the aortic valve in the heart becomes sort of calcified, the leaflets become quite stiff, and it can cause a lot of problems. So this patient was an 82-year-old female patient, severe aortic stenosis shown on a recent echocardiogram. She was referred for a coronary angiogram, which falls within cardiac cath, for a TAVI workup, which is it's a aortic valve implant, which is implanted using a catheter. The background, so obviously the condition was diagnosed via echocardiography. So the results of the patient's echocardiogram showed a calcified aortic valve. This can be seen in the two images. It's difficult to see on the top image, but if you look on the second image, in the middle of the screen, there's sort of that bright white around the valve, which in anything bright white and echo usually means calcium and indicates disease, really. So that's quite a severe case of it. When these images usually are live, so obviously they're moving. When this image was moving, there was not a lot of movement from the valve, which obviously indicates that it's quite stiff from the disease. So this is known as aortic stenosis, which restricts blood flow through the valve. The valve function is important as it allows flow from the left ventricle through the aorta into systemic circulation. So our left ventricle pumps oxygenated blood all around the body. So it goes out of that valve into the aorta to go to all the rest of the body where it's needed. So obviously quite important that that valve is functioning well, and in this patient obviously it wasn't. Typically aortic stenosis will lead to symptoms such as dizziness, shortness of breath, and chest tightness, are all associated with aortic stenosis. So when we go on to the patient's echo results, we'll go into a little bit more detail. So using clinical guidelines set by the BSE, which is the British Society of Echocardiography, we can use loads of numbers to assess the severity of the disease. Many of the parameters of what was measured for this patient fell into moderately diseased, but visually it looked severely diseased. So a lot of echo is kind of assessing the numbers versus what the physiologist deems sort of visually. So most of the numbers fell into the moderate category, apart from the aortic valve area, which was severe and close to being very severe, which definitely lent us into thinking that this was more severe for everything. So we did treat this as a severe case of aortic stenosis, and she was later referred for a TAVI, which was as I mentioned, is a implant to improve the valve's function, and make sure that try and relieve the patient's symptoms. So when we look at the photos, there's the top right is the BSE guidance on aortic stenosis. So based off all the numbers that we get from our echoes, from our scans, we'll be able to assess versus that guidance to kind of decide how severe the disease is. The second photo is just some of the numbers that I was speaking about. So we'd compare those versus the guidance to decide how diseased it is. I've circled a little bit because that will be relevant for my next stage. So keep the 33 in mind. And then the bottom photo is a Doppler from the echo scan, which is another sort of technique used within echo to measure flow through the valve. And it's another way of determining how severe the disease is. So as I mentioned earlier, within cardiology, we have two specialisms of non-invasive and invasive. Obviously, they often combine in patients' treatment pathways to make sure that sort of the best outcomes for the patient. So as a workup for a TAVI, the patient will need an angiogram to just make sure that all of the coronary arteries are unobstructed before they intervene on the valve. Basically, with such important procedures such as valve replacements or TAVIs, if there are other areas of disease, they'd much rather do it all at once, tick all the boxes, and just it just limits the possibilities of complications, infections, things like that. So if there was any coronary artery disease present, they might consider a aortic valve replacement and a coronary artery bypass, just as a whole sort of open heart surgery. But in this case, the patient's coronary arteries were unobstructed, meaning a TAVI was the best choice for treatment. So it's important that we kind of tick all the boxes and build the patient up before having a procedure, so we don't find obviously anything incidentally when we're intervening at such an important part of the patient's care. So I think I was part of this procedure, the angiogram, as part of my training for this year, which is sort of how I came to realise about this patient. So the angiogram results obviously were unobstructed, but there are, as I mentioned earlier, within cardiac cath, there's lots of other sort of techniques we can use to assess loads of different things. And with patients with severe aortic stenosis, usually the valve is so sort of stiff, you can't actually get a catheter through it. But in this case, we managed to get the catheters go through the aorta into the left ventricle. So the two pressure readings on the side there, the top one is the left ventricular pressure. So we know that just because of how big the pressures are. It basically is because the diastolic pressures are really low. The left ventricle completely empties during systole, so we'd expect that pressure to be a lot lower. The bottom pressure is the pressure reading from the aorta, and the systolic pressures are much lower than the systolic pressures in the LV, and that is the pressure gradient. So what I'd circled earlier from the echo results, we had the mean gradient measured at 33, and in the LV pullback, which is this study in front of us, we can basically see that the systolic measurement for the pressure in the LV was 117 and the aortic pressure is 87, which is pretty in line with what we were getting in the echocardiogram, and it's just another way of measuring that pressure gradient across the valve. So it's kind of a nice way to show there's different ways that we can measure gradients across valves. This is a lot more rare, mainly because usually the valve's too diseased for us to complete a study such as this. But as we were working up for this, it was good to be able to see an invasive version of gaining those measurements. So as we work obviously across non-invasive, invasive cardiology, there's a real multidisciplinary approach to working. So the case study highlights the importance of a multidisciplinary approach to cardiac diagnostics. From echocardiography, this patient would have been picked up early in a routine echo. She would have been referred to the valve disease clinic. So we have a more specialized clinic where they really focus on the valve which is diseased, just to make sure they're monitoring the progression of it, sort of assessing it in line with the patient's symptoms before deciding how to proceed with intervention when the patient needs it. A variety of healthcare professionals are involved in the patient's care. So from these clinics, the patient would have had input from the consultants, cardiac nurses, radiographers when working in the cath labs, cardiac physiologists like myself, and all the healthcare assistants that obviously help prepare patients for procedures such as this. And as I mentioned, this case study shows the importance of two different specialisms within cardiology combining to achieve the best possible outcomes for the patient's condition. So the results, the patient was successfully worked up for a TAVI. TAVI procedures are completed at Papworth from West Suffolk, so we'll help prepare them doing the echocardiograms, the angiograms, before transferring their care to Papworth for the procedure itself. The patient will then be back to West Suffolk for follow-up, so we'll sort of surveillance echocardiogram scans to assess the new valve's function. It's hoped that the patient's left ventricle will improve as a result of the new valve. Obviously, there was a lot of strain put on the LV with such a tightly restricted valve. And TAVIs have a high success rate and a very common procedure. So patients often feel that their symptoms alleviate quickly. And we're hoping that when we follow this patient up next, it will be a positive outcome.